Well, thanks for having me. Yeah, I'm from Carolina Neurosurgery and Spine. We now have 35 neurosurgeons, 1 orthopedic spine surgeon. We've got 7 or 8 offices, and we're kind of taking over the western part of the state. In the way of disclosures, I do a lot of work for Globus. A lot of these cages that we've talked about, I've done studies on. I've developed 1 or 2 of them. I do a lot of training for Globus, and I'm the far end of the spectrum, right? I don't really use static cages. I never really have since fellowship, and except for ALIF. So I'm the extreme. There's probably a happy medium between me and the other extreme, which is people who don't use any expandables at all. But keep that in mind as we go through this. And again, I appreciate you having me here. So, everybody knows that spine surgery is dynamic. It changes, right? Even in this discussion we just had, we're talking about D-lifts and combining laterals with A-lifts and posterior. Well, surgery has moved to less invasive options. You're doing things through retractors. You're doing things in a mini-open way, whether it's a mini-open T-lift or a lateral. And the idea is we got to make these surgeries safer. The morbidity's got to go down. The outcomes are being watched very closely. Likewise, open surgery has changed as well. I mean, not everybody has bought onto MIS being, the key to the future, right? As we just talked about, the structural outcomes that matter are very well known and well documented. And if you're doing surgery and you're creating deformity, you're not getting good outcomes. So open surgery, whether you admit it or not, it's changed as well. And the focus on outcomes is really where we're heading. For open surgery, things like nerve root injuries, spinal fluid leak, blood loss, OR time, all those things are important and are being watched. So as we're here to talk about the interbody fusion expandable cages, basically, these procedures are creating new challenges for these cages. So your static cage that you've been using may not be the best tool to get these procedures done through a small tube. There are better options. Likewise, if you're doing percutaneous instrumentation and you have no posterior lateral fusion, you're putting more emphasis on the interbody fusion, and you may be doing more levels of interbody fusion, and all these things need to go into your calculation as to what's the best option to use. And then finally, lordosis, especially for deformity, but really for any case. If you fuse them flat, you're going to create a problem, and you need to pick an implant that's going to give you the best chance of fixing those structural issues and not creating deformity. So, static cages or non-expandable cages have evolved over time as well. It's not to say that static cages are dead and haven't changed. It's just they've seen a lot of innovation, right? And really those 2 innovations have been in the shape of the cage. Every which way to try to get these cages in easier has been thought about. Bullet cage, banana cages, pointed cages, inserters that articulate. And now, even more recently, we're saying, well, we've maximized the shape of the cages. Let's look at what they're made of, and maybe we can get better fusion if we make these cages out of different materials. And certainly, there's been a shift towards coating on cages. There's been a shift back towards titanium, and even more recently, 3D printing, which lets you make these Swiss cheese cages that you can't machine out of titanium. So it's not that static cages are dead. It's just that these 2 lines of innovation really have plateaued. And again, here are just some options where you got different shapes, you got different points, you got allograft that's machined, you got some other ways to make the shape different. We're not really going to talk about ALL release, but hyperlordotic cages have come a long way as well. The material is now changing. 3D printing allows you to make these really complicated Swiss cheese-like cages, and that speaks towards innovation. People have thought a lot about static cages. Well, there's not a whole lot more you can do with those cages, right? It's been done, and at the end of the day, at least in Charlotte, we have moved away from static cages to dynamic cages. And just back on that, our market is basically all expandable. There's a few guys using static cages, but in my group of probably 20 guys that do T-lifts, nobody uses static cages anymore. we can talk about the cost issues and things like that later, but at least regionally there has been a large move towards using dynamic cages, or cages that change shape when you want them to. And really these cages allow you to do exactly what you did before, but they just make it easier and probably give you better outcomes, although that's still under analysis. So why go expandable? Well, basically, putting the cage in, it's just easier. I mean, there's no debate about that. And you're probably really good at putting in static cages. It's still easier to put in expandable. You don't have to forcefully impact the cage, and Globus has some good white papers on that where they look at, force of impaction. They can give you those if you want to see them. You're always going to have a solid cage. So that probably has implications for, the force required for the cage to spit out. It also is important for cases where, everything's scarred in. Maybe somebody did a posterior lateral fusion and foraminotomy, and there's a ton of scar tissue around that disc space, and you really have limited exposure to the disc. So the ease of insertion is really undeniable. Structural correction. You can get a large cage in no matter what because you can expand it up to the height you want. It's easier to place a smaller cage where you want it. So if you're trying to do like we just showed, a TLIF with an expandable banana cage, putting a small cage up front and then expanding it is technically easier than trying to stuff a very large cage in up front. So in my hands, that gives me better correction and deformity. Likewise, for laterals, for coronal correction, it's just easier to get a smaller cage in and expand it than it is to try to get a 12 or 13 millimeter high cage in through a very collapsed disc space. And then the clinical outcomes. This is where the data is not there yet, and it's being looked at. And we have a couple studies with Globus on outcomes. But basically, the idea is that retraction injuries do happen, and certainly in the early days of interbody fusion, retraction injuries of whether the thecal sac or that exiting nerve root that gets jammed by putting in a large cage. With expandable cage technology, it's hard to defend that type of injury because they don't really happen with expandable cages because you don't have to retract. So at least locally in my market, that's an issue. If you get a retraction injury because you used a static cage, how do you defend that when you have an expandable technology where you don't have to retract? Just something to think about. And then lastly, faster surgery. We're a high volume practice. Surgery times are watched closely by the hospital. There's definitely pressure to produce, and this allows you to put cages in with less time. So none of this is new, right? The expandable technologies has evolved over time. In fellowship and residency, this is all we used were these wedge-shaped cages where basically it's a type of expandable cage in an effort to make insertion easier. So they're wedge-shaped, okay? So you put them in horizontally, rotate them up to get the height, and as well you get some lordosis. The issue here is the width. Those cages are wide in the front, so you do have to retract to get them in. But this has been around for a long, long time. Likewise, there are other cages, these insert and rotate cages that have been around for a while. And the idea is you can put them in small, rotate them up, and get good correction of disc space collapse. Other expandable technologies have really been derived from vertebroplasty type devices where you're accessing the vertebral body through the pedicle, so it's got to be through a small window. And really, OptiMesh in fellowship, that was the only expandable cage we had, and we used a lot of OptiMesh. It's not approved for interbody fusion. It doesn't have structural support. It's a bag of bones, but it can be put in through a 7 or 8 millimeter cannula, and that really started kind of the wave towards thinking about expandable cages. Then along came stacks, which is basically it's a device that was developed out of vertebroplasty technology where the wafers are sequentially added and they give you expansion of this solid block of PEEK. We've seen a lot of that in Charlotte in the early days, and some of the guys in my group helped develop this technology. But it's limited, and it's hard for people to swallow this device because it's just a piece of PEEK. There's no bone graft window. you can only expand in 1 millimeter increments. And lastly, once it's expanded, you've bought it. Meaning, if you don't like where it is, you got to take an osteotome and break it to get it out. So it was all we had, but it's definitely doesn't meet all the criteria I would want in an expandable cage. And again, so we're early adapters, but there are skeptics out there, and that's okay. And basically, these peak cages that are solid, there's no fusion through the cage. Sure, I get that. The unloading of the graft in the expanded cage is a big one. So when you expand that cage, the bone graft is now unloaded. How do you get around that? And then lastly, you're going to blow these end plates, right? I mean, you're just expanding at will, and all these cages are going to subside. The cost is something that's kind of another issue which we can talk about. But these are concerns that from those early cages have been incorporated into the line of cages we have now to use. And we're at the point where most of these issues are resolved, okay? Globus, these cages have evolved over time. They've been around since 2011. We'll go through quickly some cases and pictures of these cages, but basically, it was Caliber, Caliber L, Rise, LATIS, ALTERRA, Monument, and now Rise L. So there's 5 years basically of innovation here. And each cage is different, and in my opinion, each cage has gotten better and better to kind of adapt to what surgeons want in expandable cages. They have cages that change in height, they change in footprint, they have some that translate to reduce spondies, they're lateral, anterior, posterior, and then there's bullet and banana-shaped cages. So you name it, basically, we've got it now. Really, the ideal posterior cage is, this comes up a lot, right? So ideally, you want one cage. It cuts your inventory down, right? You got one cage that you put in, and you can dial it up to whatever height you want. So you have to have a wide expansion range. You want the cage to have an open architecture so you can pack it with bone, and then you want to be able to backfill that after you expand the cage. And then finally, the inserter that you use to put the cage in has to match what you're used to for static cages. Otherwise, it's just not going to feel right, and you're going to have to change the way you do surgery. So this was the first expandable posterior cage. It's Caliber, you've probably seen it, titanium core, it's got peak end plates, and it expands. There's a bone graft window. We used this for a while before the next cages came out. This is just an example of a typical case, pretty straightforward. I think it's a young guy with a 3-time recurrent disc herniation. We fused that level with Caliber. Intraoperatively, it's a little hard to see with the sunlight there, but you get a lot of feedback because there is titanium in there. You can see exactly where the cage is. These little dots are where the end plates go when it expands. Here's a post-op x-ray, and then here's fusion through the cage at 6 months. So even though that graft was unloaded, we still do see fusion through these cages. There's differing thoughts on that, but that bone graft window does allow fusion to happen through it. The next generation cage was Rise, and this is an all-titanium cage. You can pack bone graft into the center of the cage here. Basically, the main advantage is that it has a wider expansion range, so you can put it in at 8 millimeters and expand it up to 14 or 15. So you need less cages available. Your inventory cuts down. And then people wanted titanium. Titanium's stronger, so you can make that cage expand more. Here's a typical case. Basically, a lady with a prior Harrington rod construct. She's developing some coronal imbalance, multi-level degenerative disc disease below her prior fusion. We did multi-level Rise cages. We did a bilateral approach at 5-1, and then the cages we put on one side to help correct the deformity and expanded them on that side to get her head back over her pelvis. Questions always come up about, well, you're putting this big piece of titanium in the disc space, now my MRIs are going to look awful. I can't get MRIs of the nerve roots in the thecal sac. Well, there's 3 Rise cages in there. There's a little bit of bloom artifact around it, but it's not bad. There's no cobalt chrome in that cage. It's all titanium, so you can see the nerve roots pretty well for those cages in the disc space. The next cage that came out was LATIS, and so this is not a vertically expandable cage. This cage expands horizontally, and the idea here is that you can insert the cage through a small window, expand it, then backfill the cage, and maybe it can help you avoid needing to do ALIFs. That was the idea, because you could never get a cage this big in from a posterior approach, but from an ALIF you could get a cage in that way, no problem. And that's what it looks like. It goes in like this, it expands horizontally, and then you have a little funnel where you can backfill it with all the bone you want. And we have used it on certain occasions. Initially we tried using it at 5.1 as an ALIF type replacement, and we have had good results with that. We do get good fusion through these cages. Really the issue is that it's horizontally expandable, not vertically expandable, and oftentimes we're looking for vertical height as opposed to the horizontal expansion, but it's an option that you have. Likewise, in some of these longer constructs where we're doing more deformity correction, and we will use it in place of an ALIF at 5.1, and that's what it looks like when it's open. You can see it here. It's not quite the size of an ALIF cage, but there are some that are bigger, and then you can backfill it with bone, and we do get fusion through those cages. Now lastly, ALTERRA is the newest cage. It's been out about a year now. It really meets a lot of the limitations of the prior cages in that it's titanium, okay? You can insert it. You can then backfill the cage, okay? You can place it anteriorly and then expand it to try to get as much lordosis as you can out of the cage. And this has been having very good results, as we saw earlier today. The backfilling we talked about. The inserter articulates just like you're articulating banana cage inserters that you use now, and it's threaded onto the cage just like you're used to. So you can get the cage in and out if you need to, which is really a good feature. We do try to place these as anteriorly as possible and then expand them. You can see you can place them right up against the ALL there. You can expand them, you can pack bone behind them, and you can really get good wedging of that disc space. We have up to 1 year results with them now, and we get fusion through the graft as well as behind the graft. Okay, and that's kind of the line of the Globus posterior cages. We have time to talk about lateral?
Yes.
Okay, so moving on to lateral, we've done a lot of work with expandable cages and lateral, and that's something that I do a lot of and have done a lot for Globus with, and we've really changed the whole procedure. Okay, so Globus has been very interested in getting surgeons out of the psoas muscle, so to speak, meaning, the procedure, when you put that retractor through the psoas muscle, you open the psoas muscle, you've hurt that muscle. Okay, there's nerves around it, that muscle is injured, and I wouldn't have a 4-5 lateral done to me, and I wouldn't do it to my patients through the psoas muscle. So we spent a lot of time on figuring out how to preserve that muscle, and certainly one option is direct look, where you actually dissect the muscle fibers out of the way. We've, for the last 2 years, have been doing more of a psoas mobilizing or an anterior to the psoas approach, where we try not to violate the muscle at all. That's been facilitated by some of the cages we're going to talk about. Likewise, if you're doing 3 or 4 level laterals and you're creating flat back, and that data is well known, right? The sagittal correction with lateral is not adequate for most patients. Globus has developed a hyperlordotic cage that has been out now for almost 3 years, and we're getting very good results with that. And then finally, the expandable cages have changed the operation. The indirect decompression is tremendous. The speed of the surgery is really very different than hammering in the static cages. So the lateral approach is evolving. The days of at least in Charlotte, the days of making a very small incision and just hoping you're not in bowel and hoping you're not by a nerve and looking at like an 8 or a 10 on the monitor, and those days are gone. I mean, it's just too much risk there. This is a patient with a severe kyphotic deformity. Nowadays, we're doing these through a pre-psoas approach where we mobilize the psoas muscle through about a 3-inch incision. We cut the ALL and place in hyperlordotic cages and get really good sagittal correction with a 2-level lateral, which avoids the need for a PSO in most of these patients. So with Globus's help, we've been able to really make cages that allow this next generation lateral to happen. The expandable cages, one advantage is the lack of need for trialing. So basically, once you cut that contralateral annulus and get out the disc space that you want, you're ready to put the cage in. And you've all hammered trials in and try to get bigger and bigger and bigger. There's not a lot of feel there. You're using a mallet. It's very different to put a short cage in and expand it up with continuous feedback and see how much that curve is going to give you and how much those end plates can take. The amount of coronal deformity correction is tremendous because you can access a very, very narrow disc space on the concavity of the curve and then expand it up to really as much as it'll give you. Finally, the newest cages are backfillable. You get more bone graft in a backfillable cage than a static cage. And then lastly, I think safety is an issue. In Charlotte, in town, there have been a couple vascular injuries over the years, and I think a lot of that comes from trying to put big instruments into small disc spaces. It's just there's room for error there, whether it's trying to put a 10 millimeter trial into a 5 millimeter space. Putting smaller things in is just easier. So this was the first generation lateral expandable cage. It's the same thing as a posterior caliber cage. It's got peak end plates. It's got bone graft windows. You can put it in and expand it up. We had a lot of experience with this over the last several years. Pretty run-of-the-mill degen deformity. Multi-level lateral with caliber intraoperatively gives you very reasonable correction of the coronal deformity. Posteriorly, we did osteotomies and then instrumentation to get more of the lordosis back. We use a psoas mobilizing approach where we don't go through the psoas muscle and violate the muscle or the nerves. And we get good results. This is the same case where we put LATIS at the bottom. We get fusion through the cages, okay? And this is not a backfillable cage. This was the first generation. It was all we have. But despite that, we still got fusion through the cages. We've used it with percutaneous cases, and again, similar results. Like we talked about, we've made lateral better for complex deformity. We're using expandable cages, we're using ALL release, and we're not tearing out that psoas muscle. So some of these frailer, older patients with really three-dimensional deformities, we're getting really tremendous correction. For example, after a couple level lateral with an ALL release, we get an almost total correction of that deformity. We then posteriorly have very little work to do because the lateral did all the work. So we're not needing to do multi-level laminectomies and osteotomies and all that. And here she is from the side view. You can see it's really changed the way we're doing these deformity operations. This is the most recent lateral expandable cage. It's been out now maybe since March. I think we had it a little earlier than that. It's really got all these things in it that we talked about. Once you expand it, there's a window there to backfill it. Globus has a good white paper on how much bone graft you can get in there and how the bone can fill the concavity of the end plates. It's really pretty impressive how much you can put in that cage once it's expanded. A couple kind of run-of-the-mill examples. This is an unstable spondy at 3-4. We did a lateral with a 4-screw lateral plate. Got good correction of the listhesis, and by 3 to 6 months she was fused through the cage, and that's a pretty unstable listhesis, as you could see on those X-rays. A similar example with posterior instrumentation, good reduction of the listhesis, posterior instrumentation to hold things in place, and then backfilling through that cage, because again, in these cases, there's no posterior lateral fusion. This is, I think I have one patient that's a year out now with Rizel, or almost a year at 3-level Rizel, and she's fused through those cages really nicely. So, time for one more cage? Okay. For ALIF, they've also developed expandable technology. It's a translating cage. It's called Monument. basically, you put the cage in, you put your screws in, and then you can reduce the listhesis with the cage, and it actually works. I've used it a few times. This is a failed. This is a Stax cage, the peak wafer, where basically her listhesis is worse. She's pulled out her screws. There's pseudo around the cage. What we did was basically did a regular hyperlordotic ALIF at 4.5 and then a monument at the bottom level there. These are intraoperative pictures from a different case. I didn't have them from that one, but you can see you start with the cage like this with the screws in with the listhesis there. You dial it down and it does all the work for you. Some cases you're not going to need this, right? The listhesis reduces on the table, but in some cases it doesn't, and it is a good option to have to get that reduction all done from the front, especially if you're thinking about percutaneous instrumentation or not decompressing the back, etc. And then here's what it looks like on CT. Basically, we got good reduction of this listhesis. The instrumentation goes through the anterior part of the cage, and that's basically it. So again, that's an overview of what are really the state-of-the-art cages. They're not new. They've been out for years now. The results that we've had, I think, are equivalent and probably better to what we can do with static cages. More data is coming out. There's very little data right now on expandable cages. There's a couple case series, but it's just not there yet. If you really want that data, it's just not there. So a lot of this is all from personal experience. The cost issue in Charlotte, that's all we use. So everybody's on the same level. Every company's getting an expandable now, so the costs are coming down. Globus is eating their own costs away because they make the newest cage and then they got to drop the prices on the older cages. So pretty soon the cost issue, in my opinion, is going to be basically what a static cage is. It's already heading that way for the older generation expandables. So the cost is an issue. We're fortunate in Charlotte because everybody uses them, but the costs are coming down. And that's it. So thanks for having me.